Okay, good morning, guys. And today's topic of presentation is obturation. This is probably the last aspect of the root canal system, which we have already discussed before. So today we can discuss a single part of a technique of an obturation. So what really have we studied so far during all these presentations and classes? We studied about the pulp and the periodical diseases. We discussed it about the diagnosis, the difference between a pulpal and a periodical disease. Then we discussed about the morphology of the tooth, the different canal classification like vertices classifications, veins classification. Then uh, different aspects of opening of the root canal system. How do we do de-roofing? How do we enter? Which type of burrs instruments do we use for root canal entrance? And how do we shape the canals? Which instruments do we use? What are the basic objective of cleaning the canals? The working length of the canals by radiographic means and by electronic apex locators, the irrigation systems in which we use 6% chlorhexidine, 6% sodium hypochlorite and 2% chlorhexidine and 70% EDTA. All these are intercanal medicaments if you're using a multi-visit root canal treatment. Today, we can discuss about obturation. Now, what really is obturation? This is a method of filling the root canal system. So we talk about fill and seal. So we fill by means of a sealer and we seal by means of a solid cone material, which is catapulca. The canals, they have to be sealed before putting some cone restoration over it. Now, we know that these canals, they have two portal entries. One is from the cornal aspect, which is from the pulp chamber, and the other one is from the apical end, which is from the apex. We have certain accessory canals also present in the root canal system. We need to seal every portal entry of the root canal system. Then only we can achieve a better success and a good prognosis of the root canal system. Now, what are the basic objective? The objective of putting of, of a root canal obturation is a perfect seal, a complete seal, so that there is no leakage from the coronal aspect in the oral cavity, and then there is no leakage in the apical areas through the periodical tissues. Now you see we have two types of seals over here. This one is known as a coronal seal, which is present in the coronal aspect, and we call it as a coronal restoration. And this one is an apical seal in which we confine our instrumentations and our irrigations and our root canal obturation, solid column materials, catapulca points, exactly in the apical minor constrictions of the root canal system. If we try to bypass it, we will not be able to establish a perfect seal over here. When is the time to obturate the root canal canals? First of all, uh, whenever the canals are dry, then we have accomplished the cleaning and shaping of the canals. That means the canals have been uh, cleaned from the necrotic infected debris, the smear layer has been removed from the canals, and the canal has been shaped according to the Gatapaka point shape. And when all this is completed, and then the patient complains of no symptoms at all, the canals are completely dry, then is the time that we can exactly obturate the canals. Different techniques of doing obturation. Now we have a cold lateral condensations, warm vertical condensation, compaction, max speed, and these all are different 7 to 8 techniques which we'll be discussing. But today we can discuss about a single technique, and that is known as a cold lateral condensation technique. What is cold? From the word means it is not warm, so it's at a room temperature. And lateral condensation means we are trying to put more accessory cones into the root canal systems, and we're trying to push the cones in the vicinity of the walls so that we can have more space for the accessory canal. Now, what is the basic procedure? Dry the canal by means of paper point. We have established the working length. We know the working length. We know the master apical file, and the same paper point, as same with the master cone, we'll select that paper point and we'll mark the working length on that paper point, whatever the length is, so that our gutter pocket does not try to cross the apical constriction. This is the process of drying the canal. We select the master cone according to the master file, which we have, which is the last file of root canal preparation. And this master cone, Katapaka cone, is inserted into the root canal system. And we want to feel the tug back. This tug back is the resistance which is felt in the apical one-third of the root canal system. Once when you try to put a Katapaka point in the canals, we will feel resistance when we try to pull it out. If we are unable to feel the resistance, that means something has gone wrong, and we need to again find out, do some more irrigations, and use the same recapitulations and do the same uh, cleaning and shaping of the canals. Uh, by putting that Katapaka point in the canals and feeling the tuck back, we take a radiograph. On the radiograph, we see that our Katapaka point is exactly in the minor apical constriction, which is zero point 0.5 to 1 millimeters shorter from the radiographic apex. We mix the sealer on a glass slab or on a paper pad, whatever sealer we're using, and we use a lateral spiral, which works in the rotary handpiece, slow speed, and we insert the sealer in the canals. The basic aim of putting a sealer in the canal is that we want to flood the canals with a sealer so that all the walls are filled by the sealer, because the sealer is going to uh, fill all the discrepancies. And of all, the sealer is also going to fill the accessory canals which are present in the apical one-third of the root canal system. Or we can also use a spreader to insert the sealer in the canal. So we have put the master Katapa cone in the canals, and we fill the tuck back, and now we put a finger spreader, which is lesser number as compared to the master apical file, which was the last file. And this finger spreader is adjusted. The silicon stopper is adjusted at 1 millimeter short of the working length. So if the working length was 20, then this finger spreader will be adjusted at 19. Then the spreader is rotated and it is pulled out of the root canal system. Then an accessory Katapaka cone, which is smaller, like 20-25, is inserted into the canal, and we do not need to put this sealer on the Gatapaka points, or we do not want to insert more sealer when we are trying to insert the accessory canals, accessory Gatapaka cones. The process of this accessory cones and putting a spreader again and then putting new accessory cones, it goes on. This procedure is repeated again and again until all of the canal is filled and there is no space for the accessory canal for the accessory cone to be inserted into the canals. We take a radiograph to see if there are no voids present, and the pulp and the Gatapaka point, they are cut off at the floor of the pulp chamber by means of a hot instrument. It could be condenser, it could be an excavator, it could be a plastic instrument. The chamber is cleaned by means of a cotton, and then we place a colony restoration, because the colony restoration is the one which is going to put the columnar seal. Now, these are the voids which are mostly present when we're talking about voids. These are the voids. So that means the compaction has not been done. More of the Gatapaka had to be inserted and which was not inserted. But the seal is good over here, but over here the seal is weak. This coronal seal is weak and this apical seal is good. Let's have some radiographic demonstrations of the uh, lateral condensation method. Before that, we need to find out one thing, and that is uh, the difference between radiographic apex, anatomical apex, and the apical constriction. The radiographic apex is the last portion of the apex of the root, which is visible on the radiograph. And apical constriction is exactly present in the dento-cemental junction. And this is the constriction where we need to confine our instrumentations, confine our paper points, and confine our irrigation systems, intercranial ligaments, and confine our Gattapaka point over here. If this constriction is broken by any means, then it is known as apical perforation. That has to be repaired first before we put a new Gattapaka obturation system over here. So we completely clean and shape the canals, right? And then the canals are tapered in nature. We debride, remove the necrotic tissues, we remove the dental shavings, and then we do irrigations. Then now the tooth is ready for obturation. We have the final working length, and this has to be shorter 0.5 to 1 millimeters from the radiographic apex. Now, in this aspect, we have a working length of 23 millimeters. Just remember this is 23 millimeters, right? Then the spreader is adjusted at a length of probably 1 millimeter short, that is probably 22 millimeters. We select the master cone. In this case, the master cone is number 30, as we select the master cone to the master apical file. So if the master apical file was 30, the master cone will be 30. So the master cone is 30 and the length is 23 millimeters. We put the master cone in the canals and adjust it at the same level, 23 millimeters. Take a radiograph to find out the exact nature of the tuck back and the nature of the working length. And we want to see that there is a possibility of apical resistance when we have a tuck back over here. Then we, what we do, we see the Gattapaka points on the endo gauge, and we adjust the exact length of this Gattapaka point. Then the master cone is inserted because first of all, the canal has to be flooded by means of a spreader, by means of a root canal sealer. So we assume that root canal sealer has been added into the canals, and now our Gattapaka point at the length of 23 millimeters and the color code is number 30, we insert this exactly into the root canal system. And this is the marcation which we put. We just imagine a marcation and we think that this was the exact length of the Gattapaka, 23 millimeters. If this is an indirect approach, we see from the mirror as well. And the master cone should have a different apical resistance because we want to feel the tuck back. The tuck back has to be felt. If the tuck back is not being felt, that means some problem has been achieved of there, which has to be eradicated. So we take a radiograph and we show it to our instructor. And the basic aim of showing the radiograph is that we want to see that we feel the tuck back, and the Gattapaka point is exactly in the minor apical constriction. It is not crossing the minor apical constriction. It is crossing the radiographic apex as well. We mix the sealer on a paper point. Uh, According to Grossman, we have different types of sealers. We have a sealer known as zinc solutional base. We have a sealer calcium hydroxide base, glass cement, and resin base. Resin-based sealers are very best because they have a very good property of mixing. They have a long working hours, and setting time is also increased. And the basic thing is that they are also have a good strength compared to zinc solution or calcium hydroxide. But the only drawback of the sealer is that it becomes a part of the dentine and it's difficult to remove if we want to do a re-endo of that particular tooth. The glass enamel based sealers we do not use because this has a pH of very less than 2 to 2.5, and this probably might cause demineralization of the internal portion of the antenna. Or for if you want to do repeat root canal again, this sealer will not be able to be easily removed from the canal. Calcium hydroxide is a very soft material, we have a very less strength as compared to any other material. And zinc sulfide eugenol based sealers, mostly we use an eugenol out there that will be irritant to the periradical tissues. So we don't use that probably. Now, we mix the sealer and we place the sealer in the root canal system by means of the lentil spiral, by means of a reamer, by means of a file. If we're using a file, if we're using a reamer, we will use a counterclockwise direction of putting a sealer into the root canal system. Then a spreader is inserted against that probably master cone, and it is pushing the master cone towards the vicinity of the walls so that it's creating an artificial space for a new accessory cone over here. So a new cone which is lesser than the master cone is selected and is inserted into the root canal system. Then again, the spreader is used and it is pushed into the canal. And when it pushed, it pushes the Gatapaka points in the vicinity of laterally towards the canals, and it creates a space for the new accessory cone, Gatapaka cone. So we mostly place 3 or 4 of the cones until there is no passage, no space available, no voids present in the root canal system that these cones or accessory cones could be exactly inserted into the already filled root canal system. So we see on the radiograph now what do you do? We have to remove these spreaders by means of watch winding motions, putting apical directions. We remove the spreaders with the same motion as watch winding motion, and we insert the accessory cones by means of a pre-measured. We already have measured the accessory cones and we insert it into canals. The basic aim of putting accessory cones is that all the voids, if they are present, have to be removed by means of these accessory cones. Repeat the process again and again until and unless we see that all the accessory cones have been filled and there is no more space or no more area for the new accessory cone to be inserted into the root canal system. You take a radiograph. The radiograph is taken to evaluate, first of all, to evaluate the tuck back, to evaluate the exact length of the Gattabaka cones, and at the same time to see if there are no voids which is present during the obturation, like we saw the radiograph very much before. So the efficacy of the root canal system is judged in this last radiograph we see, and if there are discrepancies present, we have to do the root canal treatment at the same time once again. Yes, the excess of the Gatapaka is cut by a cemento injection, and this is cut by means of a red hot instrument like it could be a condenser, it could be a plastic instrument, it could be an excavator, it could be anything like that. Whatever it is, it has to be sharp. So it is cut by means of a worm, by means red hot instrument, and then it is condensed by means of a small condenser, which can be easily inserted into the root canal system. Then we have to remove the sealer from the pulp chamber because over here we're going to put some columnar restoration. So the columnar restoration, if they are if, cement or sealer present on the walls of the pulp chamber, then probably our um, columnar restoration will not be able to exactly adapt itself with the walls of the pulp chamber. So we have to remove the sealer, irrigate, use a cotton, dry cotton to remove any type of tracings of sealer present in the pulp chamber. You remove the rubber dam clamps and you take radiographs. This final radiograph you see in the apical portion, which is probably the apical tuck back, and this is the apical seed, which is mostly seen, and which we always desire to have this type of apical seed. And this is 1 millimeter short of the radiographic apex. And this is the coronal seam, which is present exactly in the coron. Over here, we're going to put some coronal restorative material. So these two seals have to be very much perfect to achieve the success of root canal system. Yes, we have studied the cold lateral condensations, we, and in the next presentations we discuss about warm and compaction techniques. And in cold, we use multiple Gatapaka points. In cold, two things are very important. One is the selection of the master cone according to the master apical file. And the second of all is that the length of the working length has to be established before putting all these Gatapaka points into the root system, because we do not want to try to break the apical constriction of the root system. If we do, then definitely we have to do some work on it. Okay, this was from the Obturation Grossman's chapter number 15, and hope to see you very soon in our other lectures. That's my email. If you want to have any discussions, you can exactly incorporate your message over here. Thank you very much. Take care.